along. So a quick background about where I've come from. So my professional background is as a registered nurse, currently working at the University of Canberra as a lecturer in nursing. Prior to that, I worked at the Calvary Hospital Emergency Department, where I was one of the clinical managers there in the emergency department. Have an emergency department intensive care background in various elements of leadership management, research, education, and obviously as a clinician as well. In addition to that, I've been a volunteer with St John Ambulance for about 20-something years, joined in about 93, and had various roles in that as well, including one of my previous roles was as the chief nurse for St John nationally. Have an interest in a couple of research areas. One is planned events, such as mass gatherings, and the other one is unplanned events, such as disasters. So a lot of my research and interests revolve around those two particular areas. Today we're going to focus on patient presentations at mass gatherings. However, I like to be a little bit informal, so if you've got any questions as we go, feel free just to yell out and I'll answer them as we go. The kinds of things that we're going to have a look at today, talk about what is a mass gathering, and I'm pretty sure you've all got a good idea about what that would be. I want to touch briefly on a conceptual model of mass gatherings, and in providing care at mass gatherings, like all care that we provide wherever we are, in whatever context we are, we like to have some type of an evidence base behind what we're doing. And as you would know, from an evidence-based perspective, whether it be nursing, paramedicine, medicine, probably about 80–90% of what we do doesn't have any evidence to support that it's actually a good thing to do. So we're starting to try and build some understanding theoretically about what a mass gathering is like. So we're going to talk about what we know, and what we don't know in particular, talk about reporting of data and how we get data to come up with some research. We're going to have a look at a couple of recent research which was undertaken within the ACT region, and have a look at the impact on health services, have a look at outdoor music festivals across Australia, and then talk about some considerations for future practice which might be of interest to you. So it's pretty broad that we're going to talk about today in terms of the mass gathering context. So first of all, who can define what a mass gathering is? So collectively a crowd, yeah, people who have gathered for a common purpose normally, yeah. Right, so yeah, so a particular number. So in the literature that varies, but commonly people would say something like 20,000 people or more would be a mass gathering, but that's debatable. It probably comes down to what impact that it might have on the local health service, if you're talking about it from a health perspective. So a mass gathering of 20,000 in a city of 10 million might not have that great an impact. Whereas if you've got a mass gathering of 20,000 people in a city of normally only 10,000 people, that is a major event. So by definition though, someone has proposed that there's different types of mass gatherings. From your mega events, such as your Olympics, which are international, millions of people turning up, multi-days, multi-sites, so on, right down to the types of mass gatherings that we might see more locally, such as your local fairs and so on. So this is just one definition that exists. There are many out there. Normally, though, the aim of providing a health service at a mass gathering is to reduce the impact of the health requirements to the local community. So if you're providing a health service at a mass gathering in Canberra, the reason that you're doing that is to ensure that we don't interrupt the operational capacity of your ambulance service, that it doesn't take away from the community just by having this event, and it doesn't have a major impact on your emergency departments and hospitals either. We still want them to be able to operate efficiently during a mass gathering. And we'll come back to more about that when we do one of our case studies. So, conceptual models. This is just an idea that was proposed about 10 years or so ago now, which highlights different elements which make up a mass gathering from a patient perspective. So if someone's going to present to on-site care at a mass gathering, these are the things which influence them turning up for that on-site care. The biomedical aspects relates to their own biomedical predisposition. So do they already have diabetes? Is the crowd of 50-year-old plus people, or is it of really young people? And so on. Environmental. Is it really hot? Is it really cold? Is it undulating terrain? Is everyone sitting down or running? Psychosocial aspects as well, about crowd behaviour and crowd mood. And all of those things we're going to talk about in more detail as we go through this today as well. So from the literature and from experience, what do we know about mass gatherings? Well, the literature itself normally focuses on single case studies. So there's a mass gathering like the Olympics and someone will write about it and tell us how many patients there were there and what kinds of injuries and illnesses they had. Or there was a local dance festival and what kinds of injuries and illnesses that were there. And that's kind of interesting to get an understanding if you're going to run the Olympics again in that same place at the same time. But it doesn't really give us a big scope about what other mass gatherings might be like. They're normally somewhat descriptive, so they don't necessarily go into great detail about things which may influence other things at a mass gathering. They're purely descriptive, as in there was 55% females and 45% males. They don't then try to correlate or link things together so we get a better understanding about mass gatherings. We focus on a couple of primary outcomes. Patient presentation rates, so how many patients are actually going to turn up to on-site care, and how many of those patients will be transported to hospital, so a transport to hospital rate. Those two things are obviously important. Patient presentation rates, you're interested in knowing about that because you want to know how many people are going to turn up to your services on-site, because that's going to influence how many first aid posts or health centres you might have, how many healthcare professionals or first responders, first aiders you might have, if you need on-site ambulance and so on. Transport to hospital obviously has an impact on the local emergency medical service or ambulance service, and also on the hospitals themselves within the region. However, this relies a lot on the reporting of data, and we need to collect data from somewhere to get this type of information. If we went back and had a look at our conceptual model, we could start to pick out parts of that data. The biomedical stuff we would get from where? Patient records. Environmental stuff, Bureau of Meteorology, your own observations about the terrain, and so on and so on. So we can already get access to a lot of this data. However, we're going to come back to some difficulties in accessing some of that data shortly. So patient presentation rates we've already spoken about in terms of what that means in terms of people presenting to your first aid post. The other one is transport to hospital. So this is a graph over a 12-month period. I think it was 2007 now we did this, of St John Ambulance referring patients and patients presenting to St John Ambulance within the ACT. And if they were referred to other services such as hospitals or ambulance. So the blue line indicates presentations, and the numbers for the presentations are over here by month. The red line indicates referrals, and the referrals are over here in numbers. And you can see that it fluctuates, but the lines kind of follow one another. So that kind of makes sense, doesn't it? The more presentations you have, the more referrals you're likely to make to ambulance and hospital. You'll note that at some point in time, though, the red line's a little bit higher than the blue line, meaning that here our number of referrals were starting to get larger than we would probably anticipate. Commonly our referrals are relatively low, though. This happens for a number of reasons. Here we have large number of presentations and smaller referrals within the ACT. That normally happens around, in this year it was the 24-hour mountain bike race, which commonly has large numbers of minor injuries at it. Whereas down here we had Canberra Festival type events, where we had more events, multicultural festivals and so on, where you might actually end up having more referrals to hospital than expected. So that has an impact on, obviously, the local emergency medical service or ambulance. The thing that's not really discussed much in the literature is the referral to hospital rate, and in particular the emergency departments. So we can get a sense about that from how many people go by ambulance or referred to ambulance. Although, as you know, not everyone who gets referred to ambulance actually gets transported by ambulance. But so here we get a more accurate picture about how many people would really turn up to the hospital, whether that is self-reporting, being referred to hospital by own transport, or being referred to hospital by ambulance. Has an impact on the emergency departments. So our emergency departments in Canberra would see somewhere in the vicinity of 300 to 400 patients a day, and if on any particular day we would see 10% more than that. So if we start to see 330, 340 patients, and that 10% all comes from one event, it would really overwhelm the capacity of those emergency departments. So it would start to have an impact at the hospital level. What we don't really know too much about, though, is then the flow-on effect. Once the patient's been in the emergency department, do they actually get admitted to hospital? If they do, what's their length of stay? Do they end up in ICU, or do they go to surgery? And what's all the resources associated with that? As I said, one of the research items that we're going to have a look at tonight actually addresses some of these questions from an event here in Canberra. So, back to the reporting of data, because this stuff all relies on the reporting of data. And what do we know about the reporting of data? We rely on CAS sheets to get it, but there's a few inconsistencies around the reporting of data. So we started to have international discussions with some guys, particularly in Canada, and we've come up with a minimum data set for the types of information that we would want to collect at a mass gathering to help us build an understanding of patients presenting at these types of events. There's a lot of problems around collecting data at mass gatherings, though. One is, if someone presents with a headache, do we use it as a headache, or is it related to intoxication, dehydration, so on and so, tiredness, or so on? So how do you actually categorise a patient into a particular category? Should you use just one or multiple types of reporting for that? Do you use the primary presenting condition, they have a headache, or do you try and report the diagnosis? At the moment, there's a mixture occurring within the literature. We're pushing more so for just the primary presenting condition rather than the diagnosis, because the diagnosis normally means that you need to have some type of a workup. Whether it's pathology or imaging or other clinical skills to come up with some kind of a diagnosis. And even then, you might still have a differential diagnosis of 3 or 4 or 5 possibilities of what it actually is. Other problems in the literature around the international language, whether you call things medicine or health, are they the same things? Whether or not you talk across disciplines. So the event managers at mass gatherings call these mass gatherings events, whereas in health we call them mass gatherings and not events. So there's this miscommunication between disciplines as well. But some of the biggest issues in the reporting of data is the collecting of data and the inaccuracies in the data itself. So one of the research items that we're going to have a look at in a moment, we collected some data off patient records, and we wanted to match patients presenting on site to ambulance to the hospitals here in Canberra. That was difficult in itself because we didn't really know what patients' names were, what dates of births were, whether they were male or female, because I was just missing some basic demographic information. If they're missing basic demographic information, they're normally missing some basic other information that we might want to use, such as what is the presenting problem. So then the problem of collecting data comes down to the interpretation of the researchers and the people collecting the information to try and decipher what actually might be going on, to try and put them into some particular categories. So this minimum data set that we've come up with is primarily focused on biomedical aspects. So I said there's those other aspects, primarily focused on biomedical aspects. So the biomedical aspects, this is just the beginning of it, it's numbers of pages, but as you can see it starts to talk a little bit about the presenting problem. Things like fractures or so on you could argue would be a diagnosis, but you could also argue that's a presenting problem. You could tell if someone has a fracture. If you can't tell, it would go into something else, like a sprain or a strain or so on. This goes on for about 3 or 4 pages, focused on biomedical aspects. So first thing we wanted to do is get some international consensus of reporting biomedical aspects, and then we'll move on to some other stuff. Now, one of my colleagues in South Australia undertook a literature review to find out what data points are already being collected by other researchers. This is just some of them. And as you can see, they go across those 3 domains, from things such as the type of event, on-site medical care, the facilities, amenities, health messages. All of these things influence how many patients are going to present to your on-site care and what kind of condition they might be in. The idea that we do all of this is 2 reasons, and I'm talking from a very research focus at the moment. But from a clinical perspective, this is really important around planning for your care of patients. Once again, to know how many first aiders, responders and so on you might want at a particular event. So this can be quite extensive amount of data that you want people to collect to get a better understanding about what it might be like at those events. Any questions about data collection and so on and how we do it to date? It's kind of a little bit straightforward, hopefully. So we're now going to talk about some of the research which we're currently doing, and we haven't finished our data analysis as yet because we're still waiting on one of our hospitals to do a little bit of work there. So this is still some preliminary findings, but will give us some insight into this event in itself anyway. So this is about one event which was held in Canberra. The advantage of doing research like this in Canberra is that Canberra has somewhat of a confined population. So we know that at any one point in time there would be about 350,000, 400,000 people in Canberra. If they are going to go to an emergency department, they've only got 2 to pick, unless they go across the border to Queanbeyan. So in Canberra itself, there's only 1 ambulance service and so on. It's relatively easy to try and do some of the information gathering in Canberra. So we wanted to have a look at one jurisdiction, Canberra, which has 2 public emergency departments, so it's easy to kind of access. We wanted to have a look at one event. So we picked an event in Canberra which had about 20,000 participants, was conducted over 1 day. It was a bounded event, so it was fenced. The advantage of doing a fenced type event is that you can have some idea about the number of people who attend. Rather than an unbounded event, people can fluctuate in and out as they please. In saying that, it's really hard to get accurate numbers about how many people were at a particular event. Go out to the football matches and they put up the screen and say, oh, this is how many people were at the event. I always question it, because some people would have jumped the fence for sure, unless it's the Brumbies. That's for Shane. That's for Shane. Or, they bought tickets and didn't attend, or whatever else happens. They don't count kids or whatever. So the numbers of people actually attending particular events are a little bit fluid. This event had 1 first aid post. That 1 first aid post was connected to a medical assistance team. I can mouth up the back, that is correct. And it had an on-site ambulance. So we wanted to pick an event which was a little bit unique in this aspect itself. If you start to do some basic type of events like this, then you can start to apply your understanding to other types of events. So you might pick things that look similar but then become unbounded and so on, to try and test your theories about what it might be like. So we collected all information from on-site care, the medical assistance teams, the ambulance services and so on, and this is what we've come up with so far. So 197 people out of the 200,000-ish presented to on-site care. Of that, 2 other patients picked up the phone and called an ambulance themselves, or, we're not quite sure, walked through the first aid posts and straight into the back of an ambulance because they were so unwell or needed to go to hospital. So obviously anyway that they didn't register with the first aid on-site care. So there's about 200 patients in total. Of these, the medical assistance team had doctors, nurses and paramedics, and 34 patients were reviewed by the healthcare professionals at this event. Come back to why that's important in a moment. With 22 of them needing some care being provided within the medical assistance team. So some were reviewed and given drugs and discharged back to the event or home. Others might have been reviewed because the first responder, first aider or whoever just wasn't comfortable with the way that the patient was presenting, and the 22 needed some longer term care. So they either all had intravenous cannulas inserted with fluids and drugs, particularly antiemetics, or were sutured, or had pain relief for fractures or dislocations. That's kind of the mix of the 22 people. Of the 22 people, 2 ended up being discharged with police because when they woke up they were a bit aggressive. 5 were transported to hospital via the local ambulance service. In total, 7 patients ended up going to the hospital, including those 2 from above, with 1 patient having a stay of a day or so, intubated in the intensive care unit. So why even talk about this and what does it really mean? For a community, if we go back to the beginning where I said that the mass idea of having an on-site health service at a mass gathering is to not take away from the community, this is still putting a lot of resources into hospitals from these particular patients, like a patient in ICU from the event, 7 people turning up to an emergency department. However, when you start to drill down into the case mix and the acuity of patients, the 7 patients, 2 were related to fractures or dislocations, but the other 5 were all had artificial airways, all were sedated, and all were being bagged with bag valve masks as they arrived at the emergency departments with GCSs of less than like 13, 12, 11, 9, so on. So the acuity of these patients that are going to the emergency departments is pretty high. You guys, do I talk any lingo that you don't understand? You're all good with that lingo? Cool. So the particular events of the health teams requires people that can manage those types of patients as well. And the 1 patient that ended up in ICU was actually intubated on site at the event prior to being transported by ambulance. So there's a massive role for healthcare professionals, and for students it's an awesome practice place because, you know, within the period that you're there you're inserting, you know, cannulas, hanging up fluids, assessing unconscious patients continuously, and so on. So it's a pretty cool environment to be in. Out of the 22, 15 people returned to the event. That's quite significant because if the on-site care wasn't being provided there, those 15 people probably would have ended up in the emergency departments in Canberra. If you go back up to the total number reviewed though, the 34, you would add 12 to that 15, so 27 people returned to the event after being reviewed by a healthcare professional, which potentially could have been 27 people turning up to the emergency department. If you put that into dollars perspectives, which we haven't done yet, but you know, an ICU bed costs about $5,000 a day, a trip to the emergency department's about $500 each, so it's quite a significant amount of money too, as well as the types of resources that we're talking about. Any questions about that? So this is important to understand because if we want to then predict in the years ahead, if the similar type of event was to come up, what kind of health services we might want to provide, we would probably base it on this type of stuff. There's 2 ways to do it. Get a matrix that exists, a predictive model, and put in data about expected number of patients, the weather, and go back to the conceptual model about different variables that exist. And you can put it into a predictive model and it gives you an answer about how many patients you might expect to see. But historical data is the best data to use about what the predictor of the future workload might actually look like. To date, we're working on hopefully having better models in the future to help us do that. So that was primarily an event which included a lot of young people. But once again, it's just one event. Yeah, it gives us a good idea about stuff, but it's just one event. So what we thought we'd do is we'd do some research, and this time we had a look at multiple events. Once again, just picking on one type of event, which was outdoor music festivals. So we wanted to have a look at patient characteristics of people presenting who were young people, and we defined young people as less than 25, and presented to on-site health care at outdoor music festivals. These outdoor music festivals, yeah, sorry, there's some people just over the, are you just over the, yeah, never mind. Young at heart, perhaps. We wanted to have a look at the characteristics of people presenting, and we also wanted to have a look at the proportion and types of injuries and illnesses so that we could start to understand better the types of people that present. That's important to do because if you have an understanding about the type of people that present, you can do some pre-planning in terms of the on-site event healthcare requirements. But the other important aspect is that you could also do some health promotion. And we'll come to some health promotion types of things that you could do to hopefully reduce the workload of on-site care providers so that people can self-care for themselves at these particular events. So, we had a look at 26 music festivals across 4 Australian states and territories in one summer. And from that we had 5,500, 6,000 patients from memory. We pulled out all the young people, and we're just going to have a look at some of the characteristics now. Of patients, these young people that present at outdoor music festivals, the majority of them, 63-ish% of people, were female. Their age, obviously less than 25. And of particular note, moving on with this theme, under 25-year-old females were the most likely to present for on-site care. Under 25-year-old females laughing up the back. You've done that, obviously. Yep, that's okay. Pardon? What we'd like to do then is to try and categorise these patients into different categories. And we have 4 broad categories at this point in time from a biomedical perspective. One is people present with injuries, illnesses, environmental related factors, or mental health complaints. So here you can see that injuries and illnesses were probably some of the most significant aspects of presentations. And if there's any statistical people in the room, if there's something with a p-value that's less than 0.00 or 0.05, so this is less than 0.05, it means that it's statistically significant in one way or another. What this means here is that females were half as likely, 0.54 times less likely, to present with some type of an injury. So, in a sense, males were more likely to present with an injury. Females were 1.71 times more likely to present with an illness when compared to males. So, males present with injuries and females present with illnesses. Any theories about why that might be the case? Any theories? Why do you think that might be the case? Right, so women drink too much, perhaps, illness. Okay, yeah. So, how do you get the best view of the event? Climb a tree and fall out. Yep. What do you do if someone gets in your road? You punch them. So guys get more injuries. The illnesses are interesting because in this data set, the drugs, alcohol, or drugs and alcohol, were categorised in the environmental part, meaning that females and males kind of both presented with similar amounts of drug and alcohol or other substance or combined substance related use. So the illnesses related to other things like asthma, headaches and so on, which we're going to drill down into now. So here is the injuries. There's a lot of stuff on here and I'm just going to pick out some of the main ones. Crushing injuries. The problem, once again, with picking out these types of data from data sets is that we rely on people writing stuff down. So if it said something like crushing injury, the person coding the data would have put that under crushing injury. Whereas if we were actually there on site when it actually happened, we might not actually call it a crushing injury. Anyway, here, females were more likely to present with some type of a crushing injury. Females were more likely to present with blisters. Wear better shoes, people. Don't buy shoes the day that you're going to wear them. You know, that kind of stuff. So, males were more likely to present with some type of superficial laceration. And that's all in relation to injuries. They're the ones that are statistically significant. Yeah, there's obviously all these other ones up there with what people presented with, but these are the ones which were statistically significant between males and females. As I said earlier on, we're trying to get some understanding about the differences between groups so that we could possibly do some health promotion activities, like blisters is an easy one to do health promotion about, yeah, and so on. Next, the illnesses. A couple of people have cardiac arrests at these types of events. Chest pains. So males were more likely to have chest pain than females, although in noting of this, really there's only 13 patients overall, so the numbers are really small. So that needs to be taken into consideration to some degree. Asthma. So once again, males were more likely to have asthma than females. Asthma is an interesting one because how do we know what the normal incidence is of asthma on any particular day in Canberra? How many people are taking Ventolin on any particular day in Canberra? We don't really know. But at these types of events, we find out that there's a large number of people presenting with asthma. Headaches, which comes up shortly as well, and asthma are the two larger presenting illnesses at mass gatherings, which might be reflective of the normal community on any particular day, but isn't reflective of what we would normally see in an emergency department necessarily, or via an ambulance service on any particular day.
So do you have the numbers for how many women in the
No.
Because the percentages might actually reflect better if you compare it to the
Yeah, so the problem once again is trying to get demographic data from events, so it's difficult to get that. You could go and have a look at ticketing sales perhaps, but one person might buy tickets for 6 people. So it's really hard to get a good idea about the demographics of the overall event.
It's going to be difficult to have some kind of substance, like these statistics are all, they do show good guidance, but unless you know that, there's more female than male.
Yeah. Yeah, so the problem with a lot of the data that is presented in relation to mass gatherings is it's retrospective data. So we go after the event and look at the data that was presented before us. The better way to do it is to be prospective. So to come up with some ways that you could prospectively collect data, which is more the move now. There's very, very few amounts of prospective data. And demographic data is really hard to get hold of as well, because often people need to consent to having that released to somebody. So this is, I guess, by having a look at the types of patients that present, gives you a snapshot of what it might be like. But you still know that, more males will present with asthma than females, if that's useful, because you could still then do health promotion activities targeting young guys to bring along their asthma, staff have preventers before they come, and so on. So you can still use it to some degree, but yeah, acknowledge that it is limited in that you don't know the overall population demographics. Yep. Collapse and faint are interesting. What's the difference really? And here, females are more likely to collapse and faint when compared to males. And the other one, which isn't statistically significant, but I'll put up anyway, is headaches. Because headaches is one of those things where a large number, more than anything else, presents for on-site care. So once again, if you want to do health promotion types of activities, you might target that. In saying that, we don't know why they present with headaches, whether it's drugs, alcohol, heat, tiredness, dehydration, etc. So another body of research might be around drilling down more into these particular things to find out about why they occur. Any questions so far? Yell if you do. The other things that come up in the environmental aspects, where I said before that we have substance and alcohol related elements, is that males are more likely to present with substance related presentations, whereas the others are really not statistically significant in terms of the alcohol or the alcohol and drugs related aspects. At outdoor music festivals and with young people less than 25, we see a large number of this obviously presenting. So, what does all this mean in terms of planning for particular events and providing on-site care? Well, there's a few things to consider, and that is where the mass gathering is being held. On an international level, there are things about political, geographical, access to site type issues to think of. Same with a nation state or a state or territory in particular, the political aspects there. One is the host community. If you think of the host community being Canberra, think about what happens at particular times of years in Canberra. We might have an influx of people. Think of something like, I don't know, summer nats, for example. We get a large number of people influxing to Canberra. Floriade is another one where a lot of people come to Canberra. If you had a large event which attracted young people influxing into Canberra, it could boost the numbers of the actual host population and put a stress on the host population, because the health services don't normally change day to day in terms of their resources, physical and human type resources. But the community obviously fluctuates. In saying that too, Canberrans like to leave Canberra, and other host communities, people will also leave at particular times of the year because they know someone else is coming, so they get out, and so on. So populations do fluctuate. The event population, so we need to consider the actual event itself and the event population. They have particular characteristics which predominantly fit around that conceptual model that we showed earlier on. And then the bit that we're kind of interested in is the smaller part of all of this. It's around the patient population. Who are they? How do we provide health services for them at events? And in considering all of this, we need to plot this out on a graph, if you like, or in a manner that highlights what we know about these elements before the event, what we know about them during the event, and what we're going to do with that information after the event. So pre the event, and if we focus on stuff around the host community, event population and patient population, before the event there's some information that we can gather that helps us make a conscious decision about how much health service that we would have on site. Sometimes that's influenced by the event managers themselves, who say how much health service that they would like. So it's important for people providing clinical care to be a little bit proactive about how much influence you have into the on-site care at particular events. During the event's really interesting because not always do patients present at a steady rate. You'll have an influx of patients and then you'll have a quiet period perhaps. Depends on the type of event and the time of day and other types of factors. During the event you can also do things like surveillance of injuries or illnesses. You might start to note that people are all presenting with injury from the same place within a particular event. So you can actually be proactive in terms of providing a health promotion or health prevention in that environment. And obviously post the event, you would all do some type of, the organisations that you might be out providing a health service for would all do some type of post-event analysis so that they could improve their services for the following years. So there's lots of things to consider, and I've kind of wrapped it up in about 40 minutes or so about some of the aspects of mass gatherings and spoken a little bit about young people in particular. But we've got some time now if people have some questions. We'll talk about whatever it is that you want to talk about. I'm just going to do this very quickly, Lance, and I'll come to you. A couple of things before I get there. I forgot I put this slide in. Health legacy. So what are the expectations of the event and the health services after you leave? For example, if you provide a particular level of health service to an event, is there an expectation that the following year that the same health service would be there or not? Is there an expectation that when you go to a particular event, you're actually providing a better level of care in that community than they normally would have? Examples might be things like some of the Olympic Games. Some of the Olympics, they have like the best medical equipment in the world turn up to these events in communities where they normally wouldn't have that level of health service. So what's the kind of expectations afterwards? There's better examples from the disaster perspective. For example, the Haiti earthquake, where we send doctors and nurses and midwives to Haiti. And as a result of that, the neonatal deaths decrease, more babies survive. There are midwives and doctors and nurses still in Haiti because of the health legacy that they've left behind. It's too hard to get out of Haiti So you've got to think about that perspective and what kind of level of care you're going to provide. Changing the event site, and by that I mean is, if you have an event in Canberra, at the end of the event and you pack up and go home, where do all the people go? They just change the site perhaps. Maybe they all start to congregate in the city and go to nightclubs and parties in particular districts, which isn't really thought of. That starts to then have an impact on the community because there's no real event health services at those sites. And obviously the environmental, I'm not an environmentalist, but this is the Reading Festival in the UK. It's massive. This is all camping sites. And from an environmental perspective, if we start to drill down and have a look at this site, this is once everyone has left and gone home. All of those little bits of stuff with like tents and sleeping bags and rubbish, and tents and sleeping bags are cheap, obviously, you can just leave them behind. But massive impacts in terms of the environmental stuff. So the health legacy then is not only about the actual event itself, but what about people coming through to clean this up? It's potential for injury and illness during that phase of the event as well. So, come to questions now. Lance, fire away.
Why you said you did across one summer? Is there anything going on with winter festivals?
Right, so because we looked at outdoor music festivals, in Australia they're predominantly held in summer. The next thing to do would be have a look at different types of events across the year itself. We know stuff about summer in terms of the heat. We know that patient presentations will increase at any point in time due to heat, but once the heat reaches something like 35 degrees, then people start to get sensible. They'll find shelter, they'll drink more water and so on. And a good example of that was I went up to Big Day Out a couple of years ago now in Sydney, and it was 46 degrees at Homebush Bay. The presentations probably weren't as many as we expected. We saw, I think, about 1,500 people in a day, but people were sensible because it was 46 degrees, wore proper clothing and drank lots of water and so on. So the impacts about winter isn't really known, and in terms of how low the temperature gets before we see changes in large amounts of patients, we're not sure either. So.
Also, what about festivals that run for more than 1 day?
Right, so the other thing is the larger events, which are multi-site or multi-event themselves. There's been some stuff about, like World Youth Day, which was a multi-day event and a multi-site event. It's unique in itself as well because, as we said earlier on when we were defining mass gatherings, it's a crowd of people with a particular purpose, being in a particular space. So it's really hard then to compare, World Youth Day to an outdoor music festival that would run over 7 days as well. So World Youth Day 2008 had about 300,000 people crammed into Randwick Racecourse, which was a pretty awesome event to be at.
Yep. And just one last one.
Go for it.
So, what about the types of events, as in like if you look at festivals, Flaming Grass versus stereosonic?
Right.
Drug relation as well?
So even comparing Big Day Out from one year to another is hard because of the lineup of acts. People will go to a particular event because of the lineup that's on. So you'll see a fluctuation in patient presentations, perhaps drug and substance use, just depending on the type of event that it is. So even the same event in different cities or the same event in a different year could be completely different.
Has anyone ever looked at, specifically drugs in terms of drug use, different types of drug use?
No, there's nothing in the literature about specific types of drugs that have been used, which would probably be interesting. And I would suspect if anyone was to do that they would just find a trend in the similar types of fashion drugs that you would see on a Friday night in the city. So it would just fluctuate around what the in-fashion drug would be at the particular time. But that in itself would be interesting to know as well. However, in saying that, substance abuse and the clinical management of substance abuse is commonly the same anyway until you can determine what the substance is. And even then, we might try some reversal agents, Narcan or so on people that we're not unsure of, just to make sure it's not, because it does no harm really, just in case. So, but otherwise, the management of substance abuse is pretty much the same.
I know St John in WA has started studying surge capacity for Metropolitan Ambulance Service. Do we know anything about that for mass gatherings as well? So, for instance, a marathon might have a really high
Yeah.
surge of patients sort of 3 hours in.
Yeah.
But do you know anything about that more generally, Matt?
So in mass gatherings, once again, some of the research that we did in Canberra, we had a look at the mountain bike race, and the 24-hour mountain bike race, 24-hour mountain bike championships. So run from midday on a Saturday to midday on a Sunday with a stable population of people. We looked at it over an 8-year period. And from that, we found that of the patients that present, half of them present within the first 8 hours, and the other half present within the last 16 hours. So there's this distribution which has peaked at the first 8 hours and it peters off in the last 16 hours. So in terms of surge, you would rely on historical data to then staff that. You wouldn't at that event, shouldn't at that event, do the same level of staffing for 24 hours. Just doesn't make sense. You would stack your staffing at the first 8 hours. So hopefully we learn from some of that research to apply practically, from a resource management perspective. Otherwise, the only other types of surge you might see are from disasters happening at mass gatherings. And there's some examples of that. There's Bradford City Fire. If you haven't seen these, check them out on YouTube. Bradford City Fire, Hillsborough crush injuries. Both events had tens of people dying, 70 plus people dying at those mass gatherings. So you might see surges in relation to disasters that occur at those events, but you wouldn't staff for that. Like you wouldn't staff an ambulance service or a hospital for a disaster to happen every day. You staff it for your operational capacity and then have plans in place of what to do if that did occur. So.
Now, you were talking about the impact on the actual, on the Canberra hospitals, based on, gathering of 20,000 people in the population of 400,000.
Yeah.
If you look at, say, the 10-unit muster, 10-unit musters are around 25,000, population is about 8,000.
Yeah.
What sort of impact do you think would have on the actual health services?
Right, so the next thing that some of the work that we're looking at now is trying to do a bit more a ratio type work, so that if you did have an event of a particular size and a community of a particular size with so many resources, to try and work out what the ratio would be. And like I mentioned earlier on, if you had the 20,000 event at an event where there's in a community where there's normally 10 million people, it doesn't have that much of an impact. So no real work has been done into that, but that's certainly something that we're looking into. Because you'll have to bring in obviously more health services to those types of events. There is an event, I can't remember what it's called, but it happens on an island somewhere. Essentially, people fly in for the event over a weekend and has a massive impact on their health services. Yeah, I don't know what it's called. Probably, yeah. Yeah, so in remote Australia, or rural Australia as well, if you have large events where people travel to as well. Yeah. Question over this way?
Are you aware of any ambulance services utilising data like this to actually...
I think ambulance services are becoming a little smarter about the use of data, and particularly the use of capturing electronic patient records now makes that a lot easier to do that. The problem is, though, that the health services just don't get together and talk about this stuff. If there was an event happening in Canberra, the hospitals just wouldn't even be on their radar that it's happening. It might be on the radar of public health because they're interested in who's selling what food at the event, but other than that, they're not really concerned about the impacts on the overall health service. And once again, it's about reducing the impact, operational capacity of the health services, ambulance and hospitals, to maintain normal services to their community despite the event being going on. So the answer is I don't think people talk to one another. Same thing happens in a disaster, people just don't talk to one another either. But I think we're getting better at it. But yeah, still doesn't happen enough. So yeah, events happen, health doesn't know what's going on. Ambulance will find out about it once they get called so many times and whatever else. People think about, I'm on a shift today and there's, Summernats is on or whatever else. But other than that, people just don't think about it.
Does that correlate to, or are you
Yeah. It does. So there was some research done in Adelaide at the, I think it was a Royal Agricultural Show over a 7-year period, where they had a look at the workload of emergency services, so police, fire and ambulance. And there was definitely a correlation around the activities of all those services at those events. So yeah, if the police work increases, so would the health work. I used to get through uni, I worked as a security guard because I'm really big, and I worked at Summonats. That was pretty hairy stuff, people getting stabbed with bottles of stuff, and yeah. I sent other people, I radioed in and said there's a fight, they can go deal with that.
Just a bit of planning, how do you plan for the number of professionals and services that need to be available at the event?
Yeah. Planning for healthcare professionals is interesting because the general rule at the moment is just get as many as you can because they're hard to come by. You know, they're shift workers and whatever else. They might not necessarily want to volunteer at those types of events, so it's really hard to encourage healthcare professionals to do that. Unless they've previously been engaged in the organisation like St John Ambulance, they're probably not likely to come out with St John Ambulance to do stuff. In saying that though, you know, once again, you can have a look at the historical data to get an idea about what types of patients you might see. So if we know what that event was, you would want to plan for healthcare professionals to be at that event. So if people only wanted to volunteer a certain number of hours or days a year, you would try and target them for those particular events where you know you're going to have high acuity patients.
My understanding is that it's the event managers that organise and dictate how much health professional staff they want. So they'll go through and they'll walk through how many ambulances they want on site, how many people on site, and so forth. So that's from the event managers' perspective. It's not healthcare that's saying you have an event and we should have this many people. It's saying we're having an event in our experience we require this many people. Yeah. And they're going to negotiations for it.
That's right. And commonly that comes around from a monetary factor, that the event manager has a particular budget for health. So they will try and budget for what they think is appropriate. But it's important for the health services. My position on this would be that the health service needs to dictate to them what the requirements are. And if you're not satisfied as a health service with that, then if you're an on-site care provider, you walk away and don't be involved. That's more difficult though for other parts of health, like ambulance services, because they know that if they walk away, that's going to have an impact then on their the ability to provide health services to a community. Instead of having 10 cars on the road, you're always going to have one stuck out there. So you've always got 9 cars on the road. You're better off having one out there on site, perhaps. So it's partly about clever negotiations, I think, to ensure that you've got the right balance. I think in the future we'll see event managers who don't source the right number of and pay for the right number of health services ending up in legal type situations when patients become unwell or die.
Just on the other area of disasters and kind of leading, you know, struggle to get healthcare professionals, is there any little bit involving healthcare students in these things?
Yeah, so right. So I've always been an advocate for healthcare professional students to be at these types of events because they support the health services that a healthcare professional can provide. The idea of providing a health service at these events is to try and, from a healthcare professional perspective, is to mimic as much as possible the normal working conditions that you would have on any day within the clinical environment. And that involves students every day. So to have students there for healthcare professionals should be nothing new. And the healthcare professionals should have an understanding about what the role of students could be in those events. You know, holding up bags of fluids and stuff. Carrying equipment and things.
James told us today that he's doing research for the disaster aspect of it, the guys at the greenhouse, the walkers, to come to facilities like the CEACU and have students look after them and include education students for children and things like that. So it's something that...
Right, yeah. Yeah, that's right. So and we've written a paper in the past about nursing facilities and students and their role in a disaster. And at the end of the day, if there's a disaster happens, healthcare professionals don't necessarily turn up to work because they want to defend their own home, look after their own families and so on. Healthcare professionals, students, are the most sensible next best lot of people to use, because if you put them back into an environment which was their last clinical placement, they're going to know the staff, they're going to know where stuff is, and they can make a great contribution to that environment. But it's not written into any health plan anywhere to use them. And likewise, the facilities that are at most health universities, in terms of the labs, have better equipment than the hospitals, in terms of monitoring devices and pumps and extra fluids and lines and whatever else, the stuff that the hospitals are just going to run out of. See, you've got to come to UC. Heaps better stuff. Heaps better.
UC.
Yeah.
Any further questions, guys? All right, thanks very much, Jamie.
No worries.